Time. You have full bios on everybody, so I'm going to do very brief introductions of the speakers in the first session. And I'll begin with Larry Sherman. So Larry is both the Deputy Director of Clinical Services at the Abramson Cancer Center here at Penn. More importantly, for those of us here today, he's also the Director of the Penn Center for Global Cancer Medicine. Larry has a long history working in this space. Of course, is a renowned oncologist. Over the past 7+ years, he's been particularly involved with Partners in Health and continues to serve as their senior advisor in oncology, supporting efforts really working with the ministries of Rwanda, Haiti, and more recently, in our effort in Botswana to really think through national care programs in oncology. He's just a wonderful partner to all of us. Larry?
Thank you very much, Glenn, and thank you all for coming this morning. And I appreciate the opportunity to share my story a little bit with you, and I'm going to go through it pretty quickly so that we have time for the other speakers, but have the most time for an interactive panel and for your questions. And like Glenn said, I'm happy to hear from you in follow-up if you're interested in pursuing our work. So I am a medical oncologist, as Glenn said, and I work in primarily 3 countries outside of the U.S., primarily Rwanda and Botswana and Haiti. And the story I'm going to tell you today is mostly about the Rwanda experience, and this is our hospital in northern rural Rwanda. It's a long ways from any paved roads in a very poor section of the country, and it's a hospital that Paul Farmer established with the Ministry of Health. And for those of you who know anything about Paul, he always finds places that have no health care at baseline to try to meet the needs of people who have no other options. So my story is that I'm a clinician, and for most of my career I was a very busy breast cancer doctor, primarily in Boston. I was in the Harvard system until just under 2 years ago when I came to Penn. I did a lot of clinical research trying to develop better treatments for our cancer patients. And I also became very interested in the issue of how to best deliver cancer care. And I'm a very old guy, and when I started oncology, which was in the 1970s, there really was no structure to how to deliver cancer care. We were frankly mixing the chemo drugs on our desks and trying to figure out how to safely give them. And so being there at the beginning, I thought a lot about how to best deliver care from the patient's point of view and also from a safe point of view, and spent a lot of my career doing that. And so the idea of figuring out how to deliver cancer care in a place like Rwanda and Haiti was actually not so different than what I did here. The circumstances and the context are different, but the sort of problem-solving methodology is not that much different. And I became very involved in what defined high-quality cancer care, and I've done a lot of that nationally, and I continue to do it nationally. I'm chair of something called the Commission on Cancer, which accredits hospital cancer programs. All Penn hospitals are accredited by the Commission, and that gives me a look at how we're providing cancer care throughout the U.S. And I also am a member of the National Cancer Policy Forum, which actually in the last year devoted one of their workshops to providing cancer care in resource-constrained settings, both in the U.S., which turns out to be more places than we'd like to admit, and elsewhere in the world. So how did I get involved in global cancer care? It wasn't really on my radar through the 1970s and the 1980s. Frankly, I don't think it was on anybody's radar that I knew. At that time, we sort of felt like we had our plates full of trying to do it in the U.S. But when I was the attending physician on the oncology wards at the Brigham in the early 1990s, 2 guys were there as my interns. One was Paul Farmer, and one was Jim Kim, not at the same time. And I often say that the reason they went into infectious disease was because they didn't have an ideal experience in oncology, though they deny that. But there was another sort of one of these fortuitous things, which is this guy named Howard Hyatt, who had been the dean of the Harvard School of Public Health and was sort of a mentor at large at the Brigham. and he was assigned to mentor me because I needed a lot of mentoring at that point in my career, and he was also mentoring Paul. And so he made the link between the two of us, and we became good friends, and I tried to help Paul out in his early years in Haiti when he had cancer patients who came. And then in 2008, I was actually in Washington in the meeting, and I got called by Paul and Jim, and they asked me to try to develop cancer care infrastructure in Rwanda and Haiti, two countries that had no cancer care at all at that time. So if you lived in those countries and you developed cancer, if you didn't have enough money to fly yourself out of the country, you just basically went home to die of the cancer. And most people who live there don't have the money. And eventually I got Dana-Farber, where I was at the time, to form a Center for Global Cancer Medicine. And when I came to Penn in June of 2015, I got Penn to do the same thing. So I do a lot of things, and I just show you this slide just to say that I've been invited into a lot of forums over the last few years. And I was mentioning to somebody you'll hear from a little bit later that I always told Paul that I didn't want to be involved in policy. You know, I like doing work on the ground. I like going to places like Butaro and trying to figure out how to deliver care there and being with the patients. But somehow or another, I got into this. And I show this slide in part to say that I think that I was asked to participate in these forums because, in fact, we did do something on the ground, and we were able to show what we accomplished, and people were interested in my thoughts. So, having spent a lot of my career trying to provide better cancer care in the U.S. and develop new treatments, I think it's important to realize that if you wanted to reduce global cancer mortality more in any way than any other option, it would just bring what we do every day at Penn or places like Dana-Farber to most of the world that has no access to cancer care. A lot of cancers we can cure and impact on, but patients have no access to it. But if you're going to do it, you need to figure out how to do it effectively. Now, what does the world think about this? Most of the world, in fact, thinks that this is a crazy idea to try to provide cancer care in places like Rwanda and Haiti. And these are real quotes. The first one is from a high-ranking official at the World Health Organization who said that cancer care is too complex and too expensive, and that we would kill more people than we helped if we tried to provide it in places like Rwanda. The second quote is from the CEO of a drug company, and this quote is from this past year, basically saying giving out free drugs in cancer for cancer would not help people in Africa because we don't know how to use them. And the third one was we should just concentrate on prevention, tobacco control, HPV vaccination, all of which I agree are important, but we shouldn't get into the treatment realm in these places. And so, in spite of my efforts to not get involved in policy, this is a photograph from the World Cancer for the World Cancer Congress that was held in Paris in November of this past fall. And this is what they call a big debate. I have to say this was going on in early November before the election, the week before the election here. We had some comments about the debates that were going on in the U.S. But I was debating against Karen, who is from Australia, who would admit later that she actually believed what I believed, but she was assigned to debate the other side. So the debate was whether we should treat patients with cancer in resource-poor settings or just do prevention. And so, you know, there were 500 people in the audience that had electronic clickers so that they could vote. And before the debate, only 25% of the people in the audience thought that we should treat cancer in a place like Rwanda. And then remember, these are people who came to Paris to go to this because they believe world cancer is an important topic. So these were already sort of partly converted people, but only 25% felt that we should try to treat patients in these places. And after the debate, I got them up to 45%, so I swayed 20% of the audience, but still we were in the minority. So what about places like Penn? What should we do in this space? Okay, and this is an area I have strong feelings about, which we can talk about later. Education, should we go over there and give them some lectures, for a week and then leave? I would say that doing that alone accomplishes nothing. Accompaniment is what I believe in, and that's what Paul Farmer believes in, so it's not that I came up with such a unique idea. I just followed his directions and did what he told me to do. But in Rwanda, we've been there since 2011, so for 6 years, and I spend part of every day dealing with my colleagues in Rwanda, trying to support them, the cancer care they deliver. We provide a lot of financial support, which we can come back to if we have time, and I've already told you that I've been relatively unsuccessful at changing global cancer policy, but keep trying. And the other thing I would mention is, as you think about this as a career, we have people who work in middle-income countries like Botswana, which is another place I work, and low-income countries like Rwanda and Haiti, and those are very, very different experiences, and we can talk about that later as well. And for those of you who might be thinking about a career, is there a career in global cancer medicine? And I think the answer to that is a little bit uncertain, but we have people now, we have people in our own training programs at Penn who are doing this full time, and I think it's going to be a rewarding and a successful career, but it doesn't have a long track record, to be frank. And it's hard to find mentors, but there are a bunch of different things that you could do, and we have people who do all these different things, people who are in the trenches providing care, people who are trying to develop cancer care infrastructure, and people who are working on policy. So this is another scene from the World Cancer Congress. This was another one of these interactive sessions. And the guy on the right is a guy named Cyprian, who is Rwandan and leads our cancer program in Butaro. He's a pediatrician. He's not an oncologist. We have no oncologists there because there's only one oncologist in the whole country in Rwanda, and he actually works at a hospital that doesn't provide cancer care. That's another story, but we are training some new people. But Cyprian and I talked about what made up a good partnership between a U.S. Cancer center and a place like Butaro in Rwanda. And it was this ongoing accompaniment, but Cyprian made the comment during our discussions, which we had not rehearsed, though we're very good friends and have known each other for a long time, that the only measure of success in a program like this is survival numbers for patients. The only reason we're there is to provide better care for the patients and increase our survival rates. So our vision for cancer care was that patients should expect accessible and high quality care for treatable and preventable cancers, that the care should be affordable, and for Rwanda and Haiti that basically means that cancer care has to be free. Most of the people we see in those sites could not afford even one course of chemotherapy, no less a whole course, and all that goes along with it. And one of our mantras is that poverty should not be a barrier to receiving life-saving therapy. And finally, we should develop in-country capacity, people like Cyprian, so that we eventually put ourselves out of business, but I think that's not going to happen all that soon. Not going to go over this, but this is just to remind you that when we try to develop cancer care in places like Rwanda and Botswana and Haiti, we look at the full spectrum of what needs to happen to provide that care. You can't do any of the things on this slide as a silo. You need to address it, and we have different people addressing each one of these parts. So this is the first patient we actually treated in Rwanda before our cancer center opened. And I show you this just to show you that patients who come in, she went around for 6 months, hospital, people gave her antibiotics and Tylenol and other things, and she finally wandered into one of our hospitals where we made a diagnosis of embryonal rhabdomyosarcoma, which is a treatable cancer, and we did treat her. This is 5 years later, so we treated her in 2006, again before our cancer center was open. And she has a facial paralysis, which is no surprise considering where her tumor was, for those of you who've done your neurobiology, of course. But 5 years later, she was a very bright, eloquent young woman who is looking towards a career in medicine. And this is the second patient we treated, who's Claudine. And at the time, she was a 12-year-old living in an orphanage. And the mother in the orphanage took her around to lots of hospitals over 6 months, where they told her she had a soccer injury in her right knee, but she turned out to have bone cancer, osteosarcoma, had an amputation, and got chemotherapy, and actually was adopted by one of the Partners in Health doctors, brought back to the U.S. This is her high school graduation picture, and she's become one of our spokespeople for a lot of what we do. And when we dedicated the Cancer Center at Butaro, which I'll tell you about in a second, she was the keynote speaker. So here was this 12-year-old orphan who had a leg amputation for cancer, who then gave a keynote address to a former president of the United States, Bill Clinton, who's our godfather. And this was the dedication of our Cancer Center, and President Clinton got us into Rwanda in the first place, which is another story, which I'm happy to tell you at some point, but that's...
Just for a second and point out.
Yeah.
Yes, up there.
Yeah. I will. Good, thank you. This is what I love about Glenn, is he always tries to keep you on track. But if you go from right to left, that's Paul Farmer all the way in the right, who has been my partner in so much of this work. Jeff Gordon, who many of you may not know, and I did not know, is a NASCAR driver, or was a NASCAR driver, but he's actually our biggest funder. And he's been to Rwanda several times with me and has put millions of dollars into our program. President Clinton and Chelsea, and then Dr. Agnes Binawahu, who was then the Minister of Health and Minister of Health for most of the time I've worked in Rwanda. And as Glenn said, she will be at Penn on April 10th and 11th. There are going to be a lot of events. She's going to give a talk, I think, here, right in this room. And she's going to be meeting with students at the medical school and at the university. And she is one of the most remarkable human beings I know. I count her as a good friend, but she revolutionized healthcare in Rwanda, not just cancer care, but all of healthcare, and you need to hear that story. And outside the front of the hospital on the lower right, you can see that we have a sign that acknowledges the fact that this is a partnership between the Ministry of Health and our U.S. colleagues. So we see a lot of patients in Butaro. We see about 1,500 new patients a year, both adults and kids. And that's a lot, and we basically are the only cancer care provider in the country. So this is our pediatric ward. That's Lori Buswell, who runs our nursing program there. We've had nurses there for most of the last 5 years. The nurses are great believers in coloring books and stuffed animals, which they smuggle into the country in suitcases. But in case you think this looks like a picnic, if you look closely, every kid has an IV in their arm. Every kid was there getting chemotherapy that day for their cancer. And in spite of that, they actually look like a pretty happy bunch. And I think it's because they get tremendous support from their families and from each other and from the staff there. And sort of the joke was that every time one of them had to go get a spinal tap or something else like that, they'd all do a group hug before one of them went off to get that done. It was really wonderful to see. We do believe that if you do this sort of thing, this is an experiment, and you need to measure what you're accomplishing and prove that, in fact, you're doing more good than harm. And we've been very public about this, and this is an article that we published a couple of years ago saying that this was an imperative to show that what you've been doing. And the reason mostly that this is an imperative is if you don't know how you're doing and you don't know where you're failing, you'll never be able to do better and improve care and outcomes for the patients. But frankly, there's been a lot of reluctance to fund cancer care globally because people don't believe we can do it, and I think we need to prove to governments and to policymakers that we can do this successfully and get funded like they did fund HIV, TB, and malaria. So a couple of very quick stories and then I'll end. This is one of our patients with chronic myeloid leukemia, which is now very treatable with a pill, something called imatinib, which until recently in the US cost $40,000 a year. for the medicine, and it's a lifetime medication. It's something you have to take forever, so try to do the math on that. And the Max Foundation was able to partner with Novartis, so we get all of our imatinib for Rwanda and Haiti for free, and we have lots of patients. And we published this. This was a publication from just about a year ago, promising early outcomes from Rwanda. And you're not supposed to be able to read this, but this is a flow chart that shows you what happened to every one of the patients we treated, who went into remission, who died, who was lost to follow-up. It's all there for people to see and for us to see. But at this point, 95% of the patients are alive and 75% are in remission. And the results would be a little better if you were being treated here at Penn. But before 2011, both of these numbers were 0. So we're not where we need to be, but a lot of people are alive and well and smiling like that woman in the last slide because we can treat them. This is another picture from outside of a pediatric cancer ward. I always tell people we have shortages of all supplies there, including exam gloves, but the kids tend to get what they want. And the tall boy in the middle actually has acute lymphoblastic leukemia, or had, and is doing well. He was clearly the ringleader. But the small boy on the left is Fabrice, and this is a picture of him and his mom. They've also been spokespeople for us. They got to meet President Clinton. He was in the hospital getting treated in 2012. And actually came back. They did a video thing on him about 2 weeks ago. He's now 4.5 years down the road. He's now an 8-year-old, lovely, charming boy who's doing quite well in school. But he, in fact, is likely cured. And we wrote up our experience here. This is the most common pediatric cancer that we see, nephroblastoma or Wilms tumor. And again, this is one of those flow diagrams. It shows you where everybody's done well and where the gaps in our care were. And now, in our current experience, so we've now changed our treatment protocol to try to do better. 59% of the children with relatively short follow-up are alive and doing well. If you were at CHOP, it would be about 85%. So we're not where we need to be, but it's a lot higher than the 0%. This is one of my personal favorite slides. I show this to just say that we have a constant stream of medical students going through Bataro. This happens to be my son when he was a medical student who went over there and worked for us twice. It's how I got my tuition money worth back out of him. He did, I think, a lot of good things for us there. But we've now had Penn students going over. We had a student go over last summer, and we have 2 students going over this summer to Rwanda from Penn, and one of our MedPeds residents is going over in the next week or so. We train nurses, and this is our nursing team there, which at this point, 5 years down the road, I would put against any of the Penn oncology nurses. These are highly skilled, professional nurses who have just been wonderful, wonderful partners. And it does take a team to do this. This is one of our expat docs, Becky DeBoer on the left, with our team of doctors and nurses outside of the cancer ward there. And my last slide is this, and I show this for 2 reasons. On the left is Fidel, who, when we took this slide, was an internist at Butaro, and with one of his pediatric patients, and you can see he doesn't get along with them at all. And he's now actually in Tanzania getting an oncology fellowship. So we are trying to train Rwandan doctors. We actually found all of the funding to send him to school in Tanzania, and he'll be coming back in about a year. And on the right is who I mentioned before, Agnes Binawahu, who will be here, and this is a quote from her, which is, "Linking humility and bold vision to scientific rigor is the surest route to value and equity in global health." So with that, I'm going to end, and I hope I haven't gone too far over, but we'll have a panel discussion in a few minutes. So thank you very much.
So, as I mentioned, save your questions, and after Dave and Shanita finished, then we'll open it up for everybody. So our next speaker is Dave Isidore. Dave's an assistant professor of bioengineering and electrical and systems engineering here at Penn. Dave does many things, but one of them is developing new technologies to bring medical devices, both for diagnostics and other applications, from a first world to third and other world settings. So, Dave?
It's a great pleasure to be here. It's probably the toughest act I've ever had to follow, so don't expect too much. Lower your expectations, please. So just click this and... Aha! Excellent. So I'm going to tell you what my lab does. So I'm an engineer. This is a totally different perspective to give you sort of a quick glimpse of who I am, since this is about careers. My undergraduate degrees are in physics and electrical engineering, and then at the end of my undergraduate degree, it's sort of like, what am I going to do with myself? And if you look for jobs as an electrical engineer or as a physicist, a lot of the careers are in like how to blow things up, a lot of like military jobs, and it wasn't very appealing to me. So I went into basic science. I got a PhD in physics, and that also wasn't very appealing to me. And so sort of this constant cycle of sort of trying new things and being disappointed, and eventually life is circuitous. You kind of eventually find the path for yourself, and then hopefully that's, I think a lot of students I meet here at Penn are very kind of have a lot of stress on themselves about, what am I going to do with myself? And I think, one thing that I can maybe share with you is it's good to be wrong a lot and then sort of do a lot of course correction. So that's what I've done anyway, and it's worked out okay. So what my research is, as an engineer, I'm very interested in global health. What can I do as an engineer? And what I want to do, what my lab is very interested in, is taking medical diagnostics like we have here at the University of Pennsylvania that look like this. They're big room-sized pieces of equipment. They cost anywhere between $50,000 and $1 million. They work really, really, really well. If you come to Penn, they'll take a blood sample, they'll take urine, they'll take saliva, and they'll look for molecular markers of disease that can tell them how to give you the most efficacious treatment using these kinds of machines. And what my lab is interested in doing is taking these types of instrumentation and making them look like an iWatch. Right? And so this sounds totally psychotic. This sounds like the kind of thing, if someone told you they wanted to do this, like, why would this work? It sounds like science fiction. It is science fiction. This was invented in the 1960s by, Dr. I always forget his name, Dr. You seem like you know. Bones, yes, exactly. McCoy, that's right, yeah. So this is the tricorder. So, me and my grad students spend our days sort of working on building tricorders. And if you think about, why should this be possible, it's actually very instructional to go to. Are there any engineers here, by the way? Okay, one engineer, very good. So if you go to Town Hall or Moore Hall, we have one of the oldest, actually the oldest electronic computers in the country. And if you look at that old computer, it looks a lot like the laboratory equipment we have here at Penn. It's a room-sized machine, very manually put together, not automated or shrunken down. And so what we postulate is, because my background is electrical engineering, that we can take a lot of those same ideas from electrical engineering, how do you shrink things down, miniaturize them, integrate them onto chips, and apply it to diagnostics. So we can take a sample and all of those processing steps that currently happen in a laboratory involving highly trained people and very expensive equipment, if you can shrink them down and miniaturize them and integrate them by stealing a lot of the same technology from electrical engineering, you might be able to actually build a tricorder, and that's what we do. So what are the ingredients to the tricorder? The first ingredient is microelectronics. And so microelectronics really has its sort of early foundational basis from the 1930s or 40s or so. And since then, there's been this explosive growth in electronics. If, one of my electrical engineering professors said, if you say, what do humans make? What do we make more than anything else? Is it grain? Is it cars? What do humans make? We make transistors. Each one of these chips that makes our computers work, that make these projectors work, each of them has trillions upon trillions of transistors. And so we're really, really good as electrical engineers at making these tiny chips that are just extraordinarily complex. They can do extraordinarily complex things, and they don't cost any money, right? Because we're really good at making them in this very inexpensive, scalable way. And what my lab tries to do is take that technology and apply it to sensing biological material. So how do you get the biological material to the chip? That's sort of what my lab does. And if we think about what microelectronics does, Amazon and Teslas, which we're all going to be driving in a few years, and cell phones, and all of this is possible because of these our ability to make really cheap, really powerful electronics. So what my lab does is we take microelectronics and we combine them together with microfluidics, which is essentially just tiny plumbing. So it's how we bring blood, how we bring urine, how we bring whatever we can get from the patient to these sensors, which we can build on this chip. And the third ingredient is nanomaterials. And I won't go too much into the technical basis for this, but the short answer is that with chips, We can measure things that are physical. So I can make a camera phone that can measure light. I can make an accelerometer that can measure gravity. We're really good at measuring physical things, but biological things we're not so good at measuring. So if I say this is a tuberculosis and this is a staph bacteria, to my chip they just both look like sort of bags of salty goo. They don't look like they're that different. But with nanomaterials, I can make little magnets that will selectively stick to the bacteria, to the cells that are the cells I care about, and confer some physical property which I can actually measure with my chips. So this is what we do. And we make little chips that look like this. They're about the size of a quarter, and they can do things that recapitulate what happens in normal laboratories, and you can actually also do things that are not possible in normal laboratories. You can actually have performance that are better than using conventional techniques, because now you can actually build sensors and build manipulators that work on the same size scale as the things you're trying to measure. If you're trying to measure tumor cells in blood, or bacteria in sputum, or exosomes in serum, all of these different things, you can now build tools that are on the same size scale as what you're trying to measure. So the hope is that as you shrink things down and make them cheaper and cheaper and cheaper, that they can become more accessible. And so why do we think this is true? I always like to show this slide. This is Lagos, Nigeria. Lagos, Nigeria has 12 million people. That's New York City's 8 million people. Big city. Nigeria in general has 150 million people. Half of the United States is a huge country, right? Really, really economically booming country. But if you go back to the year 2000, when they were not quite as booming, there was one telephone for every 150 people in the entire country of Nigeria. So if you had a telephone and you wanted to sort of make a call, you had to share it with 150 of your neighbors. There was really a huge telecommunications issue in Nigeria. And how do you solve this? You have to sort of make partners with the government and infrastructure, and you have to wire. This is a very tough problem. How do you bring infrastructure to a country that sort of has this lack of telecommunications? But you skip ahead to the year 2014, there are now more phones than people. Problem has been completely solved, and it's been solved primarily by this Nokia cell phone. Right? This Nokia cell phone has totally solved the problem of telecommunications in Nigeria, because this Nokia cell phone is extraordinarily inexpensive to make, even though it's very, very complicated, and it doesn't require a lot of infrastructure. So it's a self-contained piece of technology that can be manufactured, mass-produced very inexpensively, and it doesn't require a lot of infrastructure. And because of that, it can solve this problem very quickly. And so our hope is by sort of harnessing the same type of technology, if you can make medical diagnostics that are self-contained, and they can be complicated. It's okay that they're very, very engineered and require a lot of money and a lot of investment. They can still be made very, very inexpensively and be deployed and hopefully have this really big impact on public health. So, when you think about what would it mean to make technology that's so much more accessible, there's tons of statistics you can pull on how is healthcare different across the world. I find these ones particularly instructive. If you say how many physicians are there per 10,000 people, in the United States we have about 25. If you go to Germany, it's a little bit better. They have about 37 doctors per every 10,000 people. If you go to Ghana, they have 1. Right? So it's a huge difference. If you want medical care in a country like Ghana, you have to share your doctor with so many more people. So there's just so much less access. And this has real impact. If what is the life expectancy in Sub-Saharan Africa? It's 49.1 years in 1990, 47.1 years in 2005. It's actually gone down a little bit. This is mostly because of HIV/AIDS. So these sort of lack of medical access has real impact on people's lives. And so by building technology that's cheaper and less expensive and more accessible, our hope is that you can sort of we bring diagnostics to the people, sort of take these technologies out of these sort of massive institutions where they're only accessible to those who have the money and the resources, and sort of put them out into the world. And so for us, we think a lot about underserved communities, but we also think about here in America, how do you bring diagnostics directly to physicians, directly to nurses, directly to patients? There's a lot of actual environmental applications we think a lot about. So this is one kind of commercial application where if you think about this is a reservoir in England, someone has to drive about 3 hours every week or so to collect a sample and check for pathogens. If you can just take these sensors and kind of throw them in the lake, they'll check all the time, they'll cell phone you if there's a problem. These are the kinds of applications that if you can make these types of diagnostics cheaper and less expensive, it sort of opens things up. So the short answer is that technology is, as an engineer, you can think about these really, really big problems. And it's hard, and you have to sort of do lots of engineering, and there's no guaranteed success. But it's sort of an end around. Policy is really, really tough. Economics is really, really tough. Medicine is really, really tough. But if you sort of, as an engineer, if you can get something like a cell phone, you can have these enormous impacts. So it's an interesting alternative route to have these big impacts. And so as a lab, as engineers, as trained as a physicist, how do you sort of interact in these problems, which are obviously very complicated and which we have no training in? And the answer, of course, is partnership. So everything we do, both in cancer here at Penn, we have partners at Abrams Cancer Center. In tuberculosis, we have partners in Ghana and Botswana and here at Penn. So the trick and what makes this kind of fun work is constant sort of forming these partnerships and having people teach you things and learning about the specifics of these challenges. Turns out tuberculosis, the most interesting challenge for us was pediatric tuberculosis, because there's currently not great, very poor diagnostics currently for pediatric tuberculosis, and so we've really focused our efforts on this very specific problem. The partnerships is kind of what makes us interesting and makes it successful, hopefully. So Penn's, this is a little ad for Penn. Penn's a great place for this. There's our engineering school, there's our medical school. Very few universities in the country have them so close to each other, and this kind of partnership really makes this work here. So I think that's all I've got. I could give you some more details, but I think I'm out of time. These are our chips. Yeah, that's all. And I will be happy to answer all of your questions.
Well, Dave ended on time, which is great, because I was going to ask him to speak more quickly, but I don't think that would be possible. Thanks, Dave. And there's, this wasn't by accident, so it's an interesting juxtaposition to what Larry was talking about with regard to the way that, we're having to deal with cancer, for example, at Butaro and in Rwanda now, and what Dave is talking about with regard to diagnostics. Because right now, we can't really do effective diagnostics out in the public, particularly in these remote settings. So our final speaker of the morning session, and then again, we'll bring them all up and open them up for questions, is Shanita Ziegler-Johnson. Shanita's an epidemiologist, so a little bit of a different perspective than our first two speakers. She's an assistant professor downtown at Thomas Jefferson University. Her risk focuses on defining prostate cancer risk, but what's especially intriguing about what Shanita focuses on is understanding the racial and socioeconomic disparities, both in the U.S. and globally, that impact cancer diagnosis and treatment. Shanita?
Good morning, everyone. So good to be here. I have two great talks to follow, so let's see how we do. What I'd like to do today is take you on a little bit of a journey with me, a very brief journey, of how I actually moved into this area of global cancer research and understanding some of the disparities that we see globally. So as mentioned, I am an epidemiologist at the Thomas Jefferson University, and I focus primarily on prostate cancer. However, I began my work in international cancer disparities as a postdoc here at Penn. We were very interested at that time in understanding what the genetic factors are that might be associated with prostate cancer. And when I joined this research team, Dr. Tim Rebick's research team, I decided I was very interested in studying some other risk factors, some that were perhaps modifiable, and certainly to take a look at the disparities that we see with regard to African American men who are at highest risk for developing prostate cancer and more than twice as likely as any other group in the U.S. to die from prostate cancer for reasons we still don't completely understand. I have been fortunate to work now with 2 of 3 cancer consortia that focus on individuals of African descent. We call them the tri-consortia. And the 2 that I'll talk about a little later are MADCAP, Men of African Descent, and prostate, and cancer of the carcinoma of the prostate, and AC3, the African Caribbean Cancer Consortium. As a research collaborator with these consortia, I've been involved with training and supervising the American research staff here at Penn, designing survey materials that are appropriate for those groups and populations, collecting DNA samples, which very early on we did just with a buccal swab because it was easiest, analyzing data, writing papers, developing project proposals, and currently our work as a Thomas Jefferson University PI for a new project, which is not yet funded, but hopefully will be, called BioMadCap, which is an extension of the MadCap consortium, which allows us to share tumor tissues and other biosamples among 4 U.S. institutions and 3 in Africa. And as mentioned, I focus on prostate cancer disparities and have been able to publish research for Senegalese populations, Ghanaian, South African, even East Indian, and right now we're working on a paper with Jamaican patients. So why the focus on cancer? Well, as you can see, cancer in general is a huge problem all around the world. What's really interesting, though, If you look at the top of this chart on your left, you'll see that the incidence, which is the blue line, of cancer for men and women is of course greatest in the areas where we can do the screening and detection of these cancers. However, mortality differs quite a bit, and where we have the greatest case fatality is for those less developed nations. On the right, you have prostate cancer specifically. And what's of interest here is that mortality is highest in the Caribbean, in South Africa, West Africa, Middle Africa, East Africa. So these are all men of African descent, really, that we're taking a look at. So we were very interested in understanding a little better what was going on in some of these areas. So we had a project here called SCORE, the Study of Clinical Outcomes, Risk, and Ethnicity, and it was focused on HUP patients. We were able to compare Black and white patients over time. PROGRE is a sister study that began around 2001. It's the Prostate Genetics Research in Senegal project. So it's very identical to the work that we were doing here at HUP. The surveys are almost identical, except the Senegalese are in French, of course. And this has just been a wonderful collaboration that continues to today. University of Dakar, University of Pennsylvania. We also were working with individuals at Hagi, which is the Hôpital General de Grignoff. My French didn't get any better, by the way. And our PI is Dr. Serene Gay. Dr. Gay is just an amazing collaborator. He was a general in the Senegalese army. He is the chief of urology at Hagi, and he has also served as a past president of Aortic, which is the African Organization for Research and Training in Cancer. So I'm a member of that as well. So our work in Senegal allowed us to do a number of projects, not only focusing on genetic risk factors, but thinking about ancestry, maternal ancestry in particular, diet, clinical outcomes, smoking, and we even attempted to do a study on obesity. I found out, though, that obesity is a huge problem among the men in particular in Senegal. They're very tall, very thin, so we couldn't complete that one. But we wanted to do a lot of the projects that we were doing here so that we could compare. We were focused on the hospital population initially. We have about 100 patients that we've recruited over time, and this is an outside waiting room in Senegal, so it's always beautiful weather there, except during the rainy season. We also were able to move into some other areas, into the city, in the community, and into the villages. And in fact, some of our papers that we've written, we have a population, a sample of the population that is more than 50% composed of fishermen and farmers. So very different from what we see here in Philly. So the key to really building these initiatives has been our strong collaborators. So we have Dr. Gay, we have Dr. Mohammed Jallo, who's also a urologist at Hagi. And it's just been a wonderful interaction. We've gone to Dakar, they've come to Philly and spent considerable time learning about the protocols that we could put in place. We have lab techs who are key to some of what we do. And also here is our team from Dakar going to Aortic in Cape Town several years ago. So there are some research obstacles that Aortic in particular is helping us to overcome when we think about this type of research. There are resource limitations, as you've heard about from some of our other speakers, with no tumor registries in many countries, so it's really hard to get a handle on what the problem is. And we actually think the numbers that you saw earlier are probably underestimating. And limited funding mechanisms. It's just really hard to get research going unless you can tie it into something you're doing in the US, because the funding mechanisms just aren't available in those countries. Academic issues. One of the early meetings that we had with some of our aortic colleagues, I remember sitting at a table and discussing this vacation myth. And they were really suggesting how privileged we are to be able to just do research for a living. That was so far-fetched in so many of their cultures. And the idea that we might be on a vacation if we pursue research was very interesting to me. And then there's a limited understanding about the importance of cancer in the general population, which can sometimes make it harder to recruit patients to projects. We had a number of interactions early on. We continue to have these interactions, but I wanted to point out two in particular that might be of interest to you. In 2001, when we began this project, the first face-to-face contact we had was a Penn student that we sent to Dakar on our behalf. I was expecting my first child at that time and was supposed to go and couldn't. So Sam McBride actually went for us and set up the protocols. He had been working with us on SCORE for several months. So it was a perfect match and perfect timing for him to be there. In 2005, another Penn student went to Dakar to develop dietary assessments. She did a dietary recall study with the Senegalese so that we could have an idea of what their diet looked like compared to ours. So all of that work laid the foundation for MADCAP, as I mentioned, the Men of African Descent and Carcinoma of the Prostate. The study originated at Penn. Now just the tissue biobank is here. The rest of the study primarily went to Dana-Farber. The data coordinating center is there because the PI moved. And we have sites around the US that all contribute data to this consortium for pooled analyses. And you can see we have 17 African centers involved as well, including Senegal. And one Caribbean center, I think that's the Bahamas. There's also in Cape Town a genomic analysis and DNA biobank. We used to do all of the analysis in Philly at Penn, but now they can do some of the analysis there as well. And what I'm really here to talk about is the African Caribbean Cancer Consortium, AC3. AC3 was actually the first of the three consortia that I mentioned. And I joined more recently. In fact, one of my colleagues, Dr. Avery, is here as well. We're both members of AC3, and a lot of the work that he and I have been doing with AC3 is focused more locally. We're trying to increase awareness about prostate cancer in the Philadelphia area. But what I love about AC3 is that it doesn't just focus on prostate cancer, and it doesn't just focus on the molecular epidemiology, for example. It's very multidisciplinary. And a big part of what they do is cancer registration as well, which is so key for a lot of these Caribbean nations as well. There are 16 Caribbean nations that are part of AC3 at this point, and 12 states, 17 institutions where our membership come from, and even 5 countries in Africa. Okay, and this is my last slide. I just wanted to reiterate, the PI here is Dr. Camille Reagan, and she's also the head of head and neck and lung cancer. We study women's cancers, breast, ovarian, and cervical, colorectal cancer, prostate and bladder, and a big focus on cancer registration. So for anyone who might be interested, there could be opportunities to work with either of these consortia. Thank you.
Is this on? Yeah. So we'll open it up for questions, and I'm going to take the liberty of asking the first one. Ooh, this is very comfortable. So why, look, it's a lot of work to do global work. And by global, I mean outside of your home base. It can be here in the US, it can be in a different country. But, everybody's got a day job, as they say. And if you can fit it in with the kinds of things you're doing anyway, that's great. But it's tough, right? There are different settings. You have to build new collaboration. So I just would like each of you to very briefly describe, given all these hurdles, why is it that you felt so strongly about engaging in a global component to your work? Just sort of in your heart, what drove you to reach for those goals? Shanita?
So for me, I think because I'm so passionate about prostate cancer awareness and decreasing the deaths that we see from prostate cancer here, when I saw that the problem was even greater in some parts of Africa, you can't help but want to get involved in that way. And because they have such limited resources and can't do the research on their own, it was critical that we were involved in that. Another thing is, because I'm so involved here with local populations, when we tell African American men they're at high risk for this disease, the question always comes up, well, what's happening in other countries? Are all black men at high risk? And you know, for a while, we didn't really have a lot of information we could share with them. So it's important because it also provides some of the information that we need to give our patients here.
Larry?
So, you know, when I first started doing this, it wasn't part of my job. It wasn't in my job description. It wasn't part of my day job, and I was sort of doing it around the edges. And I think with a lot of help from a lot of people, it actually now is an official part of my job. But it's not the main part. It's not really why either Dana-Farber used to pay me or Penn pays me now. And I think the comments that Glenn makes are really telling in this regard, because we don't have a lot of people who are totally devoted to this area yet, because it's just not been a solid career track. For me, you know, very frankly, it was my relationship with Paul Farmer and Jim Kim, but as much as I like them, I think just knowing them and talking to them would not have done it. It was going to places like Haiti and Rwanda and sitting in a room with an 18-year-old kid with CML, knowing that I had a pill that I could give them that would give them essentially a normal life expectancy, and we didn't have that in Rwanda, and that young person was going to go out and die because they had no access to this. And you know, after all these years, you know, I have wonderful friends in all these countries. These are wonderful, wonderful people who have just by really chance of geography, if you will, grown up in very poor parts of the world where access to life-saving treatments were not available. Very, very hard at the patient level to go there and say you're not going to try to be part of the solution. For me, and as I get older and it gets harder to sit in an airplane for 12 hours at a time, quite frankly, I keep thinking, you know, can I really do this? And then you go and you visit the hospitals, and you visit the patients, and you know, it just leaves an indelible impression on you and just makes you want to keep doing it. It's really, I think, to me, it's a very special privilege to be able to do it.
Dave?
Is it working? Oh, good. Yeah, I think like most people, sort of, you know, there's a lot of injustice in the world, a lot of, you know, you can sort of read the newspaper and just, it's very easy to get infuriated. And I think it's a real privilege to find whatever your craft is, whether it's medicine or engineering, if you have some way to sort of channel that to, you know, in the smallest possible way, make yourself feel better about sort of that you're doing something to sort of deal with these things that so upset you, all of the injustices in the world. So I think, you know, for me it's engineering, and I think for all of us that are studying different things, whether it's law or, you know, whatever it is that you're sort of here learning how to do at Penn or learning about at Penn, I think if you can find ways, whether it's global health or something else, to channel it to something bigger than yourself, that, you know, if you were to sort of, you know, sort of really engage in this and really sort of dive into it, that you can sort of make someone's lives better. You could, whatever it is that sort of, you know, you're not sitting on the sidelines just sort of saying, man, I don't like the president, which, well, anyway. But so it really sort of helps to be able to really sort of have your whatever it is that you're good at, whatever it is that's sort of your thing, to find a way to channel that to your beliefs and, you know, things that you wish were different about the world. So.
Yeah. Thanks, Dave. So I not to critique, we do have some non-Penn people here, by the way, I'm sure. So so this is for everybody. So I asked this question for a specific purpose, and that is that it really doesn't matter. I think we would all agree. It doesn't matter what area you work in. It doesn't matter whether you're a physician or a researcher or a social worker or somebody who works on policy, or as Dave said, somebody on the ethical or legal side. What's key is that you have that passion, and that, you know, it's good to go visit places that you may want to work, other parts of the U.S. or other parts globally. And for some of you, you'll get as turned on as the four of us, and it'll become a driving force for you. And if not, that's fine. So, you know, I think if you're thinking about careers in the global space, the best thing you could do is dive in, take a visit, start, and if you get struck by lightning, as we did, off you go. Okay, so let's open it up to questions. If you have them, I think, what are we doing? We have a mic in the back.
For Dr. Shulman in particular, what would you say are the rate limiting, my guess is steps in reaching how you define success. I guess the direct question is, what are the most immediate needs?
So, it's a great question, and I think part of what's made cancer care particularly challenging in these settings is that there are a lot of jigsaw pieces, puzzle pieces that need to fit together before you can safely administer cancer care. As hard as HIV was, it was actually relatively easier than cancer care, but you need to have good pathology. You need to know for sure what the patient's got. We actually use a lot of what we call leapfrog technology, which David's described, to support our cancer care, but we opened those laboratories the same day we opened our cancer center, because if you can't make a diagnosis, you can't appropriately treat a patient. You need all the supplies and the drugs. Where are you going to get them? And very frankly, the Rwandan government can't afford them and doesn't cover them, and we buy them from philanthropic support. And you need people who are trained, you need trained nurses and physicians, and you need to be able to follow the patients. And you need a database to measure how you're doing and to improve your care. And that's a very superficial answer to your question, but in each one of the sites that we work, we have actually a pretty detailed roadmap, if you will, that outlines all the things that we think we need to have in place to safely and effectively deliver care. Cancer therapy is very toxic, as many of you might know, and the worst thing that you could do is give it in a way that was not going to be safe and effective. Then you just give the toxicities with no chance to help the patient. So it's a complicated problem.
Other questions? Yeah, it's a quiet group this morning. All right, I'll ask another one. Oh, we got one? Okay, we have one here, and then we have one over there. Okay, hang on just a sec till the mic gets there, because we are taping this, by the way, so behave yourselves.
Oh, okay.
I want to be able to hear the questions.
Hi, thank you all for being
More
here.
directed to me than you.
I wanted to ask about access to medication. So you mentioned that the imatinib therapy was being made free. I can understand how, with a name like Penn or some of these premier elite institutions partnering with hospitals or treatment centers in Africa or in Rwanda, for example, there might be more, that allows for big pharmaceutical companies to be willing to share these therapies for free. What is the what's the next steps in terms of moving beyond these partnerships, in terms of making these expensive therapies available for everyone?
So you've asked a question that often makes me hypertensive. The example that I showed you with imatinib and with Novartis is the exception. It's not the rule. It's a great model, and there are now 55,000 patients with CML around the world who are on free imatinib, given out by Novartis, again, for life. And if you check your newspaper, Novartis has not gone out of business by giving this drug out for free. On the other hand, we have an editorial coming out in JAMA Oncology in the next couple of weeks, which tells the other side of the story, which there's some very, very effective but very expensive cancer drugs that the companies have been unwilling to even give to us at affordable prices. And so therefore, because I have to buy all the drugs for our sites out of the money we raise, we can't afford these drugs. And countless people die in places like our cancer center in Haiti or Rwanda because they have no access to these drugs. So we're not actually in a good spot. Every year there's something called the World Economic Forum, WEF, which is held in Davos, Switzerland. And that was held a few months ago. And 22 pharmaceutical companies did come together and talk about providing affordable cancer drugs in places like Sub-Saharan Africa. But their proposal, sort of, to be very frank, sort of like the proposal that was going on in Washington yesterday, really makes cancer care unaffordable for the majority of people in these countries. And we included in our editorial about how we thought that was an inadequate response on their part. So we are not in a good place. I showed you the exception, unfortunately not the rule.
Dave, how do you think that's going to bear out in the diagnostic market? Let's assume, and it is happening in some sectors, so you know that the nano-diagnostic field moves forward aggressively. What are going to be the barriers to access, essentially, / pricing in third world countries from your perspective?
So it's really hard to say. I mean, I think as a technologist, it's our sort of natural stance is that of like a techno-optimist. That we're going to develop these new technologies, we're going to leapfrog, and we're going to like blow up these big problems. And I think the thing that we always need to keep in mind and sort of pull ourselves back a little bit is this humility that this is going to be a tool in a much larger picture. And so if we make a better cancer diagnostic, we can catch cancer early, more effective strategies, maybe less expensive strategies might work in these places, but none of this is in a vacuum. And so, the short answer is I think there's an enormous opportunity, but the larger structural problems that lead to these great inequalities in healthcare, I mean, can't be solved probably technologically or purely technologically. I think the technology is clearly going to be really important and can really change the landscape very quickly in ways that maybe much more quickly than are possible in just purely policy ways that can really sort of shift things. But you can't get out of it. You can't get out of these impossible or not impossible. These really difficult sort of infrastructure issues and issues of equality technologically. I mean, I think a lot of people hope that's you can do that, but yeah, it's a piece of a larger puzzle.
Yeah. So if I can make two comments about the importance of David's work. In Rwanda, we've studied what factors lead to patients being lost from care, lost to follow-up. The single most important factor is whether they have a cell phone or not. Most of the people in Rwanda live in homes without electricity and without running water, no landlines, you can't call them on their home phone. Most people do have cell phones, but not everybody. And the ones that don't have cell phones that you can't keep in touch with are the ones that get lost to follow-up. So there's an example where technology has been critical. The other thing is, I told you the story of chronic myeloid leukemia and the successes we've had, but to make that diagnosis, there's a very sophisticated molecular test looking at a translocation called BCR-ABL, which at Penn is done by sophisticated technology, the computer taking up the whole room. In Rwanda, it's done by something called GeneXpert, which is, again, one of these sort of leapfrog microchip technologies, where in Butaro, where we have so little of anything, we can make a sophisticated molecular diagnosis of CML.
So I want to bring us back just very quickly to the career part of all this. So, you're sitting here with listening to a group of physicians and researchers. The reality is we can't do what you've heard about this morning without people on the policy side, without individuals working in the government sector, in the foundation sector, all of the kinds of things that I know many of you are interested in are critical to this mission. The drug pricing thing, I sat with Larry, by the way, at a meeting with a drug company who basically was trying to buy out the Rwandan Ministry of Health by offering them a gift of a machine instead of actually lowering the prices of the drug, offering basically something worth about $200,000-$300,000, whereas they were really going to make millions and millions and millions. The reality is they're not making anything because the country can't afford the drug at the price, that they want to issue. So somebody's got to influence that policy so that the doctors and the researchers can do their thing. So there's careers all over the place in this space. Okay, so I think there was another, right here in the front. Hey, hang on until the mic gets.
Thank you. My question is for Dr. Charnita. When you said there's a big need because we have a lot of lack of data in these countries, this is also true for Latin America. So I wanted to ask you if at some point your research is going to focus on make registries, populational registries, and hospital registries like more stable or more like fortified in terms of like making better the data quality they're collecting, because I think that's very important because it impacts a lot of areas, cost effectiveness of care and all of that.
Yes, that's exactly why we made it such a priority in the AC3 consortium It's so key. We don't know what to do, where to intervene, who's at highest risk, you know, when they're being diagnosed, unless we have those cancer registries in place. They're so critical to do great surveillance so that you know what the next steps are.
A quick plug for the Center for Global Health, and that is that you know, we've sort of recognized that there's a multi-pronged approach to all of these, you know, the issues we're talking about. One is great people, the most important feature, working in these areas. The second is, you know, it is beneficial to have disease focus areas that helps bring people together and form partnerships. But the other is the regional approach that Pamela just raised, and that is, you know, really clusters around essentially best case practices that can be, you know, we call them South-South collaborations or North-South collaborations, getting the different countries and the ministries together so they can share experiences and wealth. So Larry's doing this between Rwanda and Botswana and Sub-Saharan Africa. You know, we have a new effort starting, well, it's been going on for some time in Guatemala that is going to be expanding to other regions in Central and throughout Latin America. So if you're interested in particular regions, come, you know, we have a new website, by the way. So visit the website. It's up, I think, what, 2 days? Yeah, 3 days. And you'll see where we are and learn a little more about these regional strategies in addition to the disease strategies. I think we probably have time for maybe 2 more if they're reasonably quick, yeah?
Thank you. I'll try to make them as quick as possible. So thank you for the panel for talking today. I talked to Shanita before, so I'm aware, and I've heard Larry speak, and so I learn a little more each time I hear you talk. So I actually have a question for each of you, and I'll just throw them out there, and I'll make it really quick. So Larry, you had talked about one of the important issues is to how can you show we have an impact. So, so could you, and I saw the list of committees and everything that you do, that you serve on. So maybe you could recommend some committees that if people are starting out in a career that you may want to try to serve on so that you could have an impact. And I guess for Shanita, the question I had for you was, so there are cultural differences between African men and men in the U.S. So what were some barriers that you faced in talking to men in Africa which made this information more difficult or easier to get out of them? And then for David, I wanted to ask you about, does your lab create projects that are specific to that region, that if you have low resources, do you see what they have and kind of come up with some ideas? Like, for example, I know an issue in Africa is the power grid is an issue. So there was a company in Germany that created a solar-powered LIDAC. There's a lot of sun in Africa, so that's a good idea. So does your lab do those kind of things also?
All right, so we're going to run out of time. So let's do it quickly. Dave, why don't we start with you?
Yeah, I think with engineering, what makes engineering fun is when it becomes specific. When you're trying to, you know, just like if you ever watch Project Runway, you know, you make a much better dress when you're given really good constraints. You know, it has to be done in an hour. You need to use this material. Engineering is the same way, and it's very interesting, and you make really nice designs when you have constraints. And yeah, the constraints of working in resource-limited settings are really interesting. So one sort of thing that really stuck with me, we were working in a clinic in, you know, really far out in rural South Africa, you know, really far from the grid. You know, they didn't have running water, they didn't have any electricity, but most of these guys had cell phones. And because they didn't have access to electricity, what they would do is they would take their cell phones and they'd turn it on once a day and use it for text messaging, and then turn it back off again. And maybe once a week or once a month, they'd go to a place where someone would charge a bunch of batteries with a solar panel, and then they'd sort of switch out their batteries. And so that's how they sort of had this technology, but they repurposed it to make it work for their lives. And so
that's enough.
Yeah,
we got to keep going. Actually, need it quickly. We're going to do it in reverse order.
Okay. Yeah, so there are some cultural differences between African Americans and Native Africans that you brought up. What made it tougher, I think, or at least maybe different to do the research in Senegal was that a lot of the men had never heard of prostate cancer, and there was a serious fear of cancer. We find that in some of our communities here, but not to the extent that we saw it there. Also, it's a primarily Muslim country, so there were certain questions on our American questionnaire that we couldn't ask there because they didn't think it was appropriate, like about alcohol intake. So it was just not acceptable, even if they I guess they probably would not drink, but at least they're not supposed to. So we couldn't ask certain things, and we had to add other questions to incorporate their diet, that sort of thing. And of course, the language barrier. So we always had to have people to facilitate for us with the surveys.
And my brief answer to your question is get a lot of experience in the front lines, in the trenches first, because that's going to be what gives you the most powerful voice at any of these other forums. And I often tell my team, when you go to these forums, you can tell in about 4 nanoseconds when somebody's speaking whether they really know what happens on the front lines or whether they just read it in the book or on YouTube.
Okay, so we're going to take a 10-minute break and then come back. Please hang in there because the second session will be just as interesting, if not more so. And after that, you get fed lunch.